Thank you for having me here. It's a pleasure, and we'll see. Basically, I will do my best to confuse you a bit, because, you know, things are not that solid, and there's not a lot of consensus about many of the issues concerning medical use of cannabis. A major issue in the introduction of cannabis into the clinic as a legitimate means of medical treatment is the resistance of the medical community, the discomfort not only of the regulators, but specifically of those people who are responsible for administering the treatment itself. This is a very charged issue, and as far as I can tell, it really is the major issue at hand. There are places where the medical use of cannabis has become legitimate, and yet the doctors themselves are still uncomfortable with that. A good example is in Canada. Okay, I'm not representing, I have not surveyed all the doctors in Canada, but there are some issues which come to mind and are exemplified in the instance of a patient who came to me from Canada. She was a young lady with metastatic breast cancer who had brain metastases. She was doing well as far as control of the tumor itself was concerned, but she kept on having seizures for years on end from the site where the metastasis had been extracted. And she came to me with a permit from a Canadian doctor who told her that here's the permit, but he didn't know how to instruct her how to go ahead with it. Okay, how to proceed and make use of the cannabis to control the seizures, which is astounding, and it really makes one raise, wonder what is going on. One of the issues, of course, has to do with the preconceptions concerning the use of cannabis. Okay, so obviously it is stigmatized, and there's a lot of stress placed on those who are expected to administer the cannabis, both in terms of their own comfort. Many of the physicians feel that they are displaced, so to speak, out of their comfort zone when addressed with the matter of cannabis. I can tell you a fact from Israel that nowadays many of the doctors, even those who have patients who describe positive experience with the cannabis in controlling various symptoms, will tell their patients that they acknowledge the benefit of the cannabis, but they will not intervene, they will not make the effort, they will not take the step to go ahead and provide them with a permit. Okay, and why is that? Practically every patient who comes to my clinic presents me with that question sooner or later. What is the problem? Why don't they want to provide the cannabis? And it's a fact. We can start from that. I wonder if the same situation prevails here in Slovenia. I have had some discussions with other people from other countries, and it seems that is rather a universal problem in the Western Hemisphere. I don't know what's going elsewhere. In Singapore, it's a problem for sure. So how to overcome that obstacle? Well, I can tell you something from my personal experience. The point is not that it's my experience, but it exemplifies the whole issue. I was introduced to the medical use of cannabis by chance. I'm a neurologist, and I encountered several patients with sets of symptoms, mind you, not diagnoses. Now, there's a whole field of discussion. How are you going to authorize the use of cannabis? Are you going to focus on symptom control, or are you going to allow it only for specified indications, specified diagnoses? Okay, so I can imagine that there is a sort of mixture that is more adequate for many reasons, and that is something for you who intend to use cannabis, something for you to consider, because on the one hand, it is effective in certain in management of symptoms and specific diagnoses. On the other hand, let's say if we have a patient with painful spasticity, the chances are that it's going to be effective even if you are not quite clear as to the specific diagnosis of the disorder causing the spasticity. Okay, so then you could say, well, it could be indicated for a symptom. Now, these are things that are of concern for us as physicians intending to arrive at clinical decisions on the one hand, and on a different level, of course, we have to cope with the perspective of the regulators who are authorizing our activity one way or the other. Now, so the physicians have certain preconceptions, that is obvious. Generally, they always joke about it, and they have all these ridiculous jokes, you know, maybe you will give some to me, and even in formal courses, so-called educating the doctors about the medical use of cannabis, they'll put up a slide of an old lady, and they'll tell the stupid joke about a grandmother with cancer who got cannabis to treat her symptoms, and all of a sudden all of her grandchildren started to visit her frequently, okay? Suggesting that the benefit is for the children who are coming there and exploiting the presence of cannabis in her home. And the point here, which I'm mentioning, is that it is suggested in a derogatory stance, okay? It is viewed as something that does not pay much respect to the patients who are using it, or to the notion of using it for medical purposes. And to that I could add, of course, that one of the most effective ways of really bringing benefit to an old lady with cancer is to have her grandchildren visit her no matter what the reason. And that is a serious remark. Okay. So there's a question here between a very tightly defined scientific approach to the use of cannabis, and there is a broader clinical approach whereby the standard for determining whether to use cannabis or not and in what manner is derived from direct observation of the impact of the addition of cannabis to the assortment of medical interventions he's receiving. Okay? One of the interesting things about cannabis, and everybody has talked so much about the complexity. One of the things, there's so many things. One thing is outstanding, of course. We are so complex. There are so many modes of intervening on so many levels. Cannabis has effects on the molecular level, on the cellular level, on the level of the organ, on the relationships between activities. Okay, let's say the whole HPA axis regulating and all kinds of phenomena associated with stress, and on the organism itself. Okay, so there are so many levels. It's so complex. Now let's take something simpler. Let's take an old car with it's stuck in the snow, and you attach a hook. Now, if you attach it the wrong place, you will simply pull off the front fender, right? But if you attach it where there's a metal loop and you take it, you will be able to drag it out of the snow. So that is a strategic point of intervention. And it appears that cannabis, the administration of cannabis can elicit a very distinct signal. So you give people a small amount of this substance and you have a remarkable effect on the whole organism. You transform its state of well-being. That is something that is phenomenal and which is very difficult to break down into all these specific molecular elements, of course. We will never be able to integrate all these assorted elements of information in order to get the greater image. It does not mean that studying these specific effects is not effective, but it does mean that as a clinician, perhaps, there is another way to approach the whole issue, and that is to pay more respect to clinical observation per se. We have not made any advance in the clinical use of cannabis for over more than 100 years. The doctor who, Sir Reynolds, who was treating Queen Victoria towards the end of the 19th century, made exactly the same comments that Professor Uri Kramer has made a couple of minutes ago. There are some things that we have to take into consideration in this context, okay? There is always this question of safety or lack of safety. And actually my workshop was, well, how to introduce cannabis to the patients. So this is one of the first issues that arise in the encounter, okay? And that is why I'm without anything behind me, because when I have patients in my clinic, I don't present them with PowerPoint presentations, of course. I simply discuss the matters with them. There are different situations, of course. There are patients who have experience with cannabis. There are many who do not. There are many patients who have relatives accompanying with them. Some of them come along with suggestions and questions. The interaction between the physician and the patient and his entourage, the family and friends or whoever comes along, is critical, of course. And it's same as in any other field. We simply have to act as clinicians who have a sufficient degree of empathy, of understanding, of collaboration, of understanding that we are actually on the same side with the patient and not struggling for control and trying to determine whether cannabis is under my control or not. Because as it happens nowadays in Israel, in many cases, that is what happens, and there is a lot of tension between the physicians and the doctor. And I can imagine it happens elsewhere as well, because people who are under severe medical stress, suffering from various symptoms, occasionally even with previous experience, using cannabis to alleviate their symptoms, and they come to a doctor and the doctor denies any knowledge of efficacy or any scientific basis for their claims. Obviously that is a situation which will give rise to a lot of tension and aggravation and negative results. In any case, when I have patients, even if I'm receiving them between one and another and I don't have any time at all, there are certain things that I insist on presenting and informing them. One is that cannabis indeed is safe. It is safe. And people can go around and say there are all kinds of situations where there are side effects. When we are talking about safety as physicians, actually we have to say, just a moment, we're not talking in absolute terms. We know that there are side effects. We know that it drops blood pressure and that it drops glucose levels and that it can induce panic attacks in a minority of the cases. This is something that we all know and acknowledge, and we inform the patients. However, if we go beyond that, then essentially we know that even administering doses 10 or even 100 more than the recommended dose will not result in irreversible damage. And indeed there are reports of people who have been exposed to such high doses and they were even assumed to be in a coma, but within 24 hours they walked out of the hospital as they, in the same physical situation they were in prior to receiving that That is not to say that there are no side effects, okay? But it is safe, and as Professor Kremer pointed out, all these side effects have been noted to be reversible. And that is a universal observation on a reasonable level. I have had some experience with significant psychiatric side effects which did require adjustment of the treatment or its discontinuation. I'll remark on that in a minute. There was a question also about regarding interactions. And one of the interactions which is out there, anybody who knows something about neurophysiology or in any field of neurological medicine will open his eyes and say, well, how come aren't we made aware of it? It is known that the cannabinoids, or several of them, do have an impact on the monoamine oxidase activity. So they inhibit the MAO activity. And that is something that is significant among a large proportion of our patients who are receiving antidepressants. Okay? So I came to notice that because I had an elderly patient receiving one of the SSRIs, and he was started on cannabis, and he was developed hallucinations, which was contrary to my previous experience with cannabis actually alleviating hallucinations. And I looked into it, and I understood that he was also taking this SSRI, which was only intended for some kind of mood disorder, or perceived as mood disorder on hand of his physician. Instead of discontinuing the cannabis, I simply lowered the dose of the SSRI. Okay, and then all the hallucinations dissipated, and he was doing well and gained benefit from the other beneficial effects of the cannabis concerning his pain, concerning his ability to sleep at night, concerning his nausea. There were other occasions also where patients received a combination of SSRIs, or especially SNRIs, with the cannabis, and they became agitated to an excessive extent and on the verge of being psychotic in a small number of cases. So all you have to do in that case is to lower the dose of the antidepressant. That is what I did, and it was effective. This is not something that has been published, but this is what we do in the clinic when we have no other choice. When we have a patient with a set of symptoms which are completely uncontrolled by any other means, cannabis is doing well, and all of a sudden we have to cope with this apparent interaction. So what can we do? We can say, okay, there's nothing written in the book about it. We are simply going to discontinue the use of cannabis and let the person get along with his symptoms, or we can try to respond otherwise by lowering the SSRIs or the SNRIs. Now this is an example, because what it represents actually is not a specific item of information. What it represents is an approach. And I believe that taking into consideration the immense complicity or complexity of the cannabis itself, of the medical disorders, and of the human organism, which we forgot to mention, because not all people react in the same manner to the cannabinoids, not only on the pharmacokinetic level, also on the pharmacodynamic level. If we take into consideration all that complexity, which we cannot foresee whenever we will find a formula which will enable us to predict exactly what's going to happen, then we need another approach as clinicians, or to abandon the whole notion of treating people. And a very simple common sense approach is to administer the preparations and observe their effect. Now, this is not the traditional way we have been taught to practice medicine. Actually, I had this insight in the course of discussing this approach to medicine in general, and I am primarily practicing in the field of palliative care, where it is easier to implement because the symptoms are available and there to observe and monitor. But the notion is that instead of using some kind of deduction from a set of rules proposed to us by the medical institutions, guidelines from which we derive what is correct and what is not, we can enter the interaction with the patient as a quest, okay? So we are presented each and every time with a new situation, a new patient, new issues. And under those circumstances, we try to do the best with whatever tools we have at our disposal, and we make progress, and we monitor it. Now, if we would be using something that can cause irreversible damage, we have to be much more careful. But if we have the confidence that we do have with cannabis itself, and not all kinds of synthetic derivatives, mind you, which are a different story. But cannabis itself, we know to be safe, and then we can administer it and observe the response and proceed from there. One of the interesting things with cannabis, which sets it apart from the way we usually approach pharmacotherapy, is that its impact is diverse. So, for example, I'm seeing a lot of cancer patients. These cancer patients are suffering of a whole host of very many different things that are adversely affecting their ability to experience a meaningful life without too much suffering. So they have pain, they have nausea, they cannot sleep at night, they suffer of stress, okay? The cannabis is the only drug which I am aware of which can simultaneously address all these various aspects of their suffering. And then we have the question, of course, of adapting the specific preparation to the needs of the patient. If we are flexible enough and we have broad enough a range of different cannabis preparations, then we can adapt the treatment to the specific patient's situation. Normally, we give them more than one form of cannabis. We give cannabis for night treatment, we give them for the day. Sometimes we give a different variety of cannabis, chemovar or whatever, for acute states that occur in between. For the acute states, we give them something to inhale because the effect is rapid. For the sleep at night, we can give them oil or something, even something to swallow. Clinically, based on experience, anybody who will gather the experience with patients will very rapidly, in collaboration with the patients themselves, identify what is useful for the patient and what is not. The question is a matter of being open, having open communication, and having the flexibility to shift from one form of use to another. Now, this is a completely different vision, which has to do with practicing in the field. This does not have much to do with the vision that the cannabis industry has nowadays. Okay? Actually, we could say that there are two parallel processes taking place nowadays in the context of medical use of cannabis. On the one hand, we have the medical institution with its traditional approach under the confines and under control to an extent of all kinds of conceptions of the pharmaceutical industry and what is legitimate and what is not. And what they are trying to do is to educate the cannabis, so to speak. They're going to bring it into the limits of what is acceptable to medicine nowadays. At the same time, there is an expansion or a potential for expansion of current medical practice to encompass other forms of treating people in the clinic without some of these strict rules, while still maintaining a strict commitment to the well-being of the patients. So we will be able to give more varieties of the patient, we will be able to give the doctors more leeway to make a choice what to give and what not to give along the course. When we are working in the clinic, we are not implementing something with foresight, saying this is what I'm giving you and this is what's going to happen. Okay? Each and every case actually as a new experience, and we provide it together with a patient and who tests it on himself, and together each one with his own professional or personal perspective arrive at the conclusion if it is doing better for him or worse. And from there we can work on and improve the situation more. And for a fact, this is an approach which is clinically effective. The problem is to give it the form which will be acceptable to the institutions who are actually putting us in the position as physicians to provide health to the population. Do you have any questions? I have a question. If it makes any sense to you, and if this is something that you can implement some way or the other.
Yeah, thank you very much for excellent presentation. The way I understood it was that you suggest that for all this complexity we should pay more attention to clinical observation. Of course,
definitely.
As medical doctors, we all follow evidence-based medicine. And originally, evidence-based medicine was always not meant only to follow the data, which are not clear. They had many determinants, this data. So originally it was about the data, and then it was about clinicians' experience. This is what you emphasize, that how important it is to observe. And the third, you also mentioned the open communication, and you meant this dialogue with patients, and we should respect patients' need and their concerns and even their ideology. This was originally meant by evidence-based medicine, but nowadays, especially in the field of use of cannabis and cannabinoids in medical field, mostly the profession and the policymakers are thinking about data. You know, they always say we want more data, and they don't respect clinical experiences and even patients' demands and needs in this. And during my work, I found out there is even the fourth dimension, and this is the context. And just a few days ago, I got this neuroscience news report, and there is research from Columbia University, and the name of the research, the article, is cannabis use disorder more prevalent in conservative states. It was a big study made in the United States, and they were comparing the states with which has medical cannabis legalized and states which were conservative without this legalization. And they found out that use disorder, this is something biological, this is something that has a substance, clear...
Or sociological, it's hard to tell.
Cannabis is more prevalent in conservative states. So I said, why don't we hypothesize that cannabis treatment is more effective in liberal states? So what I want to say that we have these many nice dimensions within the evidence-based medical science, which we can follow and present this to our colleagues and to policymakers to improve the conditions for the work and for our patients.
I would say two things. First of all, there is a common misinterpretation of evidence-based medicine, which is based on, well, our being so concerned with defensive medicine and litigation and all sorts of problems from that aspect. Even in the original classic on evidence-based medicine from 1996, the name of the first author escapes my mind at this moment. It starts with a B. In any case, it was emphasized there that the data that is accumulated from rigorous clinical trials is only an aid to the judgment of the clinician in field, and it can never take its place. And in fact, even today, even when we have rigorous trials and a lot of solid information on treatment of various conditions, and there are well-defined clinical guidelines based on Cochrane database and whatnot, there is always in the summary a remark that the guidelines are only to serve to guide the decision of the clinician, who has to ultimately arrive at a decision of his own based on the specific nature of the situation he is dealing with. Okay? But there's a misinterpretation, and everybody says only looks at the presence availability of data from the clinical trials. Another thing is, there's a lot of, I've been talking a lot, and then you say, okay, but what does that boil down to? So, okay, so some of the doctors will be bit more flexible and compassionate, and some will be less. But there is a sense of policy as well. We need empowerment, and we have to delineate where the limits are between the formal structures authorizing the administration of medical health and the interface with the patient. And as I see it, the physicians need more autonomy, they need more empowerment from the authorities so that they can actually practice on their own. Otherwise, what happens is that the physicians, in many cases and in many different contexts, not only in the context of cannabis medicine, are not implementing medicine as they would have done if it was up to them alone. And they are simply tools, puppets of a bureaucratic machinery which is dictating their medical decisions. And they need more independence. Now, this is a plea, I don't know, but I think it is an observation, because what happens with cannabis is that the doctors are afraid to use it. They are afraid to use it, and they say, well, no, I will not give it. So, first and foremost comes the confidence. I will give it to the patient, it is safe, I will follow up the patient, and I will see what happens. As we accumulate more and more knowledge, if we accumulate that knowledge systematically, clinical observations can also be recorded, no doubt. And we can collect those clinical observations if the physicians feel comfortable administering the cannabis and collecting the information. And then that can be organized, and then we can provide Professor Meiri with better information from which we can arrive at better solutions for various situations, break down do things a bit more intelligently. But for a start, obviously, the way is, there's this story about how many phone calls do you have to make in order to arrive at the telephone number of the president in the White House. Because it's an exponential process. And the same is when you're using cannabis. Okay? To arrive at the effective species, chemovar, at this point, to identify the appropriate treatment, it is much easier to give a patient one species for the morning, one species for the night, follow up 3 days after, and within a week, you will have something that is effective for that patient. If you are strictly confining the patient to a specific cannabis-based preparation, and you're saying, our research says that is what's effective, and if it is not working for you, you will not get anything, we will be missing out on a large population of patients who can benefit from cannabis. And we will be spending much more time trying to identify some kind of effective treatment.
In Slovenia, there's a huge gap with physicians, with education, with having even the basic information about cannabis and cannabinoids, because no one taught them in medical school, and later it's up to them if they take the time and go deeper into the subject. Mm-hmm. How is it in Israel? Is there something already systematically how physicians would be educated or at least know, because in Slovenia patients are, they don't dare to speak to medical doctors about this because there's still this huge prejudice about it.
Yeah, well, I think there are two aspects to that question. One is the emphasis on the gap in knowledge. I must say, the first time I gave cannabis to a patient, I had very little clinical experience. I had some knowledge, and after that I read up a lot, of course. But I didn't need that knowledge in order to achieve an effective treatment for that patient. So what I'm saying is, this gap in knowledge often serves many of the clinicians as an excuse simply to keep away from that dangerous field of cannabis. So they say, there's no knowledge, we haven't been educated, and so on. It's true. Actually, the way we learn is from example. So when we train as physicians. We don't learn. It is not cookbook medicine. So they simply have to see and then follow and try, see one, do one, teach one, right? That's what they teach the doctors. That's how we learn our profession, our trade. The other thing is, as far as teaching, the question is really what is relevant. I must tell you, the graphs Professor Mary put up there are interesting in their own. The biochemical diagrams of the structure of the molecules are very interesting. They are completely irrelevant to the physician in field. If I give someone, a patient, a prescription, the most important thing is that I don't write like a traditional doctor and write down the prescription so that the pharmacist can understand what was written. But the structure of the molecule on that level of action is completely irrelevant. And when the doctors are complaining about lack of education, they're complaining about knowing or not knowing if it's passing through here or passing through there. There are a number of fundamental facts, of course. So you know that cannabis can be taken by inhalation, you know that it can be swallowed, you know that it can be administered transmucosally. You could imagine after 30 seconds of consideration that if you swallow it, it'll be absorbed a bit, it'll take more time to be absorbed than if it's inhaled, okay? And if you talk to the patient, then he will tell you, wow, you know, actually in Israel we have a system of so-called educating. The first time a patient in Israel is provided with cannabis, he goes and receives instruction in the use of cannabis. And this is, of course, the result of the initiative of whom? Of the regulatory authorities? No way. Of the doctors? No way. This is a result of the initiative of those so-called untrained people who were there administering the people, the cannabis to the patients, the so-called bud tenders or whatever. Okay, they are usually people who have their own experience with cannabis, and they bring this old 75-year-old grandfather with cancer and have him take a seat and explain to him that maybe he'll feel a little like this and a little like that, but it's okay, they're together with him, next to him, and have him take a puff and give him something sweet to drink, and he gets along, and after he has that initial experience, they know to go a little like this or a little like that. That also has to do with one of the questions which was raised before. Is it possible that, you have that habit of taking the same cannabis all the time? Sometimes it has one effect and sometimes it has the other. Well, let's say, which is quite, I doubt it, but let's say that the cannabis is completely uniform and every time you get the same cannabis. Most chances are that you got something completely different in terms of the content of the effective molecules. But even if it's the same cannabis itself, there is ample research clarifying that the effect of cannabis on the CNS is dependent and is modulated, is modified by the context within which the cannabis is being used. Now, we don't have to be geniuses. Everybody here probably had some kind of alcoholic beverage sometime along his life, his career. And you know that the same drink, same amount, same concentration of alcohol, under certain circumstances can have a wonderful effect, and under other circumstances will have a devastating effect. So these are things which are context dependent. Our CNS is constantly modulated by all its input, not just by its chemical and genetic makeup. Okay, the fact that I am here standing in front of all of you in a room of such this temperature or the other, that I'm speaking in a language which is not my mother tongue, etc., etc., all modify the way my CNS will function, and it will react differently to the same intervention.
I have a question which it's related to this. When you have cancer, then the effect of cannabinoids, let's say, are basically known as a mechanism, basically. And this does not affect on my mood or on my, I have cancer, and cancer cells will then respond, probably, depending on the type of cancer, context of the cancer. And if you would know genetics of the cancer and of the patients, then you can predict the response that would fit into this setup of genetics, pharmacology of the same patients. So each patient would then be different, but responding cancer would then respond on the whole environment and of this tumor that you can know in advance. So if you also consider the genetics of the patient, let's say you decide on the symptoms, you said, you decide on the diagnosis as a physician, of course, and that's very valuable clinical observation, absolutely. But if you would know genetic background of the patients, or let's say I'm talking about tumors only, not any other effect of cannabinoids, which is complex, would you think that that would help you to predict how the patient would react, having all the genes known and all the information on, of course, different patients?
Well,
this is individualized.
This is a different ballpark.
Yeah.
Okay. Basically, as far as the clinic is concerned, there is a concept of symptom clusters.
Yeah.
Okay, and we adjust the treatment, the symptomatic treatment, to the symptom clusters. And there are certain situations. The knowledge of use of medical use of cannabinoids nowadays is not advanced enough to implement something of in the line of the vision that you present. So I know, for example, that patients with thyroid cancer who are being provided with high doses of the thyroid hormone replacement are suffering from a certain set of symptoms such as rigidity, agitation, diarrhea, etc., etc. And I know that certain species, chemovirus of cannabis will aid them, okay? So I can associate a certain treatment to a certain disease, but that is not what you mean. So as far as treating the cancer itself, that is a completely different issue, because here we are considering the use of cannabis for an objective which we cannot titrate according to response. We can nowadays, to a certain extent, in certain diseases, because some of the diseases have markers that we can monitor. So we have I don't know, various biochemical markers for pancreatic cancer or cancer, ovary cancer, etc., etc. And we can already, after a few treatments, get some kind of notion whether we are actually impacting the process of the disease. But beyond that, to accumulate, to implement a different form of knowledge, where we do need much more of the scientific-based knowledge, at this point we are not there. I think that one of the advantages of the symptomatic benefits that we have from cannabis is that it makes it legitimate for us in many conditions to provide patients with cancer, suffering from cancer, with cannabis to treat their symptoms. Alongside that, we can derive all this other information, because we can study what impact this cannabis has on the tumor in vivo, because we are treating everything. We are modifying the microenvironment of the tumor as well. I can give you another example, for example, which suggests that this is effective. Nowadays, everybody's talking about checkpoint inhibitors in cancer. This is a family of drugs which modifies the interaction between cells of the so-called immune system, which is actually a housekeeping system, right? We have cells which clean up our body and take away all the bad parts and repair, etc., etc. They also attack, one branch of this system also attacks bacteria or helps control viral infections and so on. But it's much more, has much broader effect. It actually helps us with the housekeeping of our body. So this immune system sometimes is evaded by the tumor, by the cancer. The cancer sort of presents a false passport. You know, the cell from the immune system comes and checks this cancer cell and says, "Show me your passport," and he gives them a counterfeit, a false passport, and he says, "Okay," and lets him pass through. And these modern drugs have developed a way to identify some of these counterfeits. So the cancer cell says, "Here I have a driver's license or a passport," and the immune system, the cell from the immune system says, "Oh, you know, that was a nice try, but I know that you are a bad cancer cell," and it will kill him. So there are these new drugs nowadays which have enabled us to really make a step ahead. We are just studying this as this novel medical care in several forms of cancer. Now, as has been noted there, the cannabinoids repress some of the activity of the cancer of the immune system cells. They are less aggressive. Okay? So people who are treating with these modern drugs say, "Don't give cannabis because you know, we want the immune system to be more aggressive against the cancer." And now we have experience with several patients who have been taking high concentrations of cannabis together with these checkpoint inhibitors, and astoundingly, the responses are very, very good, more than expected. So this is something that also already gives you the idea that maybe it is also affecting the environment, the immune environment and so on, and not just affecting the cells themselves specifically. But that is just a digression. I understand that I've gone way beyond my time. Thank you very much. If you want to ask me something or anything else, you can approach me later on and we can talk.
Thank you.